back to the Childhood Cancer Perspective, and thank you all for joining me on this weekly episode. This week, I do have a guest with me that is the Chief Scientific Officer at Carthera. I'm a clinical stage medtech company advancing brain therapy through innovative ultrasound-based devices. Something close to our family, as everybody knows, is brain cancer, and something that we want to be able to find better advancements for treatments and things like that going down the line. So today, my guest is Dr. MichaelCanney. Welcome to the show, and please tell us a little bit about yourself.
Well, thanks so much for having me on today. As you mentioned, I'm the Chief Scientific Officer at Carthera. We're a company that's developing a new treatment modality for treating brain cancer. Specifically, right now, we're focused on glioblastoma, but I think the technology we're working on has other applications as well, and we do have a trial ongoing in childhood brain tumors. But what we're going to talk about today is really overcoming the blood-brain barrier, which is a big obstacle to treating brain cancer, and our solution that we've been developing for doing this.
Absolutely, and that's a very specific topic, is the blood-brain barrier. Going through this journey with our daughter being diagnosed with choroid plexus carcinoma, which is a very rare form of brain cancer with not a whole lot of good options out there to treat it. The blood-brain barrier is something that I didn't even know existed until about 2 or 3 rounds of chemo, when we were told that we need to go to high dose to actually break that brain barrier. So I would love for you to explain it a little bit deeper and how we're kind of getting past that in different types of therapies.
Yes, the blood-brain barrier is something that's pretty unique to the brain. And so what it does, you can think about it as a structure in your blood vessels that basically stops things from crossing over. So most organs, I think if you inject a drug into the bloodstream, it crosses relatively freely over into the tissue that blood is perfusing. In the brain, if you inject something, it doesn't get across. And actually, some of the first studies that were done that saw this was they injected this kind of blue tracer. I think some of the first studies were with some different tracers, but they injected a tracer, into an animal model, and you can see this tracer that lights up the whole body. And then you look at the brain and you don't see any of it there. And so this is how they kind of, I think, discovered the blood-brain barrier, that it is this protective structure. And you can think of it as, there's, maybe we won't get too complex about it, but basically, it limits what can cross into the brain tissue as a protective structure for the brain. But because of that, most drugs don't really cross into brain tissue. And so about 98% of drugs can't cross the blood-brain barrier. They just can't really get to the tissue that blood supply is perfusing in the brain. And so if you look at that, in terms of kind of quantitative metrics, most drugs will have kind of 100%. Like if you give a drug in the blood, the ratio between the tissue that's perfusing in the bloodstream may be on the order of 100%, because that drug just crosses over. In the brain, we only have maybe a few percent of that drug actually gets into that brain tissue. And so oftentimes drugs maybe are not as effective in the brain. They don't cross over. That really limits what you can use for treating something like brain cancer, because we just can't get enough of the drug there to have a therapeutic effect.
Yep, no, absolutely. I was agreeing. That's something, like I said, that I didn't know about in the very beginning, and it wasn't really explained to us, going through. And as you mentioned too, there are very few, I think maybe 1 or 2, there are very few chemotherapy drugs and traditional treatments that will break that barrier and actually get into the area where the tumor or the cancer is present. And without that, essentially you're treating the rest of the body for where the cancer is not currently integrated. And that's something that was surprising to me, to say the least, when we were going through things. And there's several different types of treatments just in general. You have, with brain cancer, you have radiation, chemotherapy. Generally, surgery is your best course of action to remove the tumor if possible. Chemotherapy is generally administered through a port. You have options of intrathecal chemo, which I wish we would have had that opportunity. What is something, or what is different about what you are working on that could treat this in a different way?
Yeah, so what we're working on is using ultrasound to actually mechanically disrupt the blood-brain barrier. And so this is something that's been studied for about 20 years now. We're now moving into human trials. We're in a phase 3 trial, but we did the first human patient treated in 2014 with this. And so we can use ultrasound basically to temporarily disrupt the blood-brain barrier. And so when we disrupt it with ultrasound, we can get a disruption that lasts for only a few hours so that it restores itself, so we don't have any real toxicity from having a sustained disruption of the blood-brain barrier. And when we do that, drugs can cross over and actually get into that brain tissue. And so for some of these drugs we talked about that maybe cross very poorly, we can increase the concentration of that drug by 5-fold or more in the brain tissue and make it more effective.
Okay. Is this so? Your therapy or the therapy with the ultrasound kind of disrupting that blood-brain barrier, is that being used, then it's being used in conjunction with traditional chemotherapy treatments?
Yeah, exactly.
Okay.
Exactly. One of the benefits, as well, is that, we use this kind of medical device to deliver a drug, but we can repurpose a lot of these drugs that already exist that don't cross over the blood-brain barrier, which is in contrast to doing, a brand new drug development, which can take very long time, 20 years, 10 years, 10, 20 years really for a brand new, molecule to get into clinical use.
Absolutely. And have you seen, I know you said that you had a first patient that you had done this in 2014, and are you seeing positive results with this that could move into more of a, be as somebody's standard toolbox to be able to use as treatments come up?
Yeah, we are getting closer to that. And so we did the first in human trial in 2014 in France, established the safety of the technique. And then we've done some improvements on the device that we're using, which is an ultrasound implant that a surgeon places at the end of a surgery. So it's a little bit unique in that aspect, in that we actually have an implant that goes in. You mentioned surgical resection. This is oftentimes the standard of care for a lot of brain tumors. And so for a neurosurgeon to go in, when they do a surgical resection, oftentimes they can't get all of the tumor. And this is why they're oftentimes, most of the time, they're very deadly, is because there's always some cancer cells left, depending on the type of cancer. We're focused right now on glioblastoma, which is a very invasive cancer. And so when the surgeon goes in, they can at least get some of the tumor, but there's almost always residual cancer cells. And so to treat those residual cancer cells, as we mentioned, they're oftentimes behind the blood-brain barrier. And so if you're to give another drug after that, oftentimes that drug just doesn't reach those cancer cells. And so here we're placing our device as an implant basically to replace a bone window that the surgeon goes in to access that tissue when they're doing the resection, and activate it when the patient gets a chemotherapy. And so when they get the chemotherapy, be it every couple weeks, every month, depending on which drug they're administering, we can disrupt that blood-brain barrier and kind of open the door for those drugs to cross over and to get to that brain tissue.
And have you, I guess I would say positive, but is there any negative side effects to having this done or to have that blood-brain barrier disrupted?
Yeah, that's something we're continuing to look at. Right now, we've seen some transient neurological effects that happen when we do disrupt this blood-brain barrier. So patients will get dizzy, they can have headaches, they can have some interesting sensations. I've had one patient tell me they felt like they were drunk, when we were doing these treatments, which was kind of an interesting sensation. So we're having some kind of neurological effect, but in most of these patients, these adverse events, I would say, resolve within this kind of time course of the BBB restoring itself, which happens within a few hours. So usually within a few hours, the patient feels normal and they don't have any of these feelings anymore.
Okay. And this is, when you're going through cancer treatments, like I had mentioned before, patients are introduced with like a central line or a catheter or a port, something like that. So what this is an implant, is this something that is permanent, or is it removed after treatment is completed?
Yeah, so the device can be removed if a patient has another surgical resection. It could be removed in a unique procedure. A lot of patients elect not to go in for surgery and just keep it if they aren't really bothered by it. So it just depends on the patient. But most patients we've had on trials have not had it removed, unless they've had a specific surgery, another surgery for another resection procedure.
So the next question then, I guess, well, my question would be, what about glioblastoma is the reason to really focus on that type of brain cancer? Not that it's more or less important to any other type, but what about glioblastoma is the focus right now?
Yes. There's a lot of research in glioblastoma, and the main thing is really the unmet need. There haven't been a lot of new treatments for glioblastoma in 20 years. There's the drug that we're using. You mentioned that there's very few drugs that cross the blood-brain barrier. The drug that's used for glioblastoma is a drug called temozolomide that was shown to be effective in a trial in 2005. And this is 20 years ago. This is still the standard of care for these patients. And the trial that showed that it was effective moved the median overall survival by 3 months. So, not a huge effect, but enough to get approval, enough to benefit patients. Since then, there's been one other medical device that's been approved called the NovaCure device. It's very different, uses electric fields to slow down tumor growth, has also shown some effects, but there haven't really been any other new therapeutic modalities for treating this cancer since then. And because of that, overall survival remains very low, on the order of 1 to 2 years for these patients when they're diagnosed. And so this area was an interest of the founder of our company, who's a neurosurgeon in Paris named Dr. Alexandre Carpentier. He's been working on new treatments for glioblastoma in particular for a long time. And so he founded the company around this idea of bringing this ultrasound technology to these patients and seeing whether we could have an effect, whether we could repurpose drugs that maybe have been tried and haven't crossed the blood-brain barrier very well, to see if they could be more effective and really increase survival in these patients.
Has there been any looking into the other forms of brain cancer of where this could also be effective? I mean, obviously the focus right now of glioblastoma, but have there been other patients or other types that have been brought up that this may work as well?
Yeah, I think it's not limited to glioblastoma. I mean, if you go down to lower grade, if we're talking about adults, lower grade gliomas, I mean, there's still a need for new treatments. The trials are just a little bit more difficult, longer, can take a longer time to run because the cancer is slower growing. So there's some practical aspects about running trials in these patients. We also do have a trial running in childhood brain tumors in high-grade gliomas in children, because actually one of our first people I worked with. So I've been with Carthera since it was founded and lived in France for a long time when the company was founded back around 2009, 2010. One of the first people that helped in some of the early research was a pediatric neurosurgeon named Kevin Beccaria. He's practicing in Paris. He's running a pediatric trial for us as well to explore this for these patients. But we also get a lot of interest for people who are working in the DIPG space, which is a huge unmet need. I mean, also not many treatments for these kids that get diagnosed with DIPG. There's a great researcher at Columbia named Dr. Lisa Konofagu who's running a trial actually using a little bit different device, but the same principle of using ultrasound to disrupt the blood-brain barrier and testing this out in these patients as well. So I think that the number of indications is definitely beyond glioblastoma. This is really just a starting point, and different labs are investigating some of these other indications as well.
Right. And I know that just in general, that when it comes to investigating or researching any type of cancer, it depends a lot on, especially with pediatrics, it depends a lot on the sample source and sample size, amount of kids, and DIPG, DMG, ATRT, these are all horrible and almost deadly at diagnosis cancers that there's not a whole lot of options, and kids can handle these therapies a lot differently than adults. So any options out there for our kids and for adults, especially for, again, parents like me that, with a type of cancer that most people unfortunately have never even heard of. I think I have located 2, maybe 3 doctors that have actually studied it or understand it. That's scary because there's not a lot of options out there. So you mentioned in the beginning that you're in the phase 3 part of clinical trials, or in that stage of getting through and things like that. Can you explain a little bit more what that is, or what that process is, and at what point this might become kind of widely available?
Yeah, so I mentioned we treated the first patient in 2014. After that, like I said, we improved the device a little bit to make it bigger and to cover a larger region of brain tissues to really enhance drug delivery. And we ran a phase 1-2 trial, I would say, that we completed a couple of years ago and published. And this really established the safety, and we started to see some interesting efficacy signals. And in particular, we had some groups where we varied when we gave the chemotherapy relative to this opening of the blood-brain barrier using ultrasound, and started to see some very positive signs, I think, in some patients. Not all patients, of course, responded, but enough that we were encouraged, I think, to move forward to the next step. And the next step is really a phase 3 trial, as you mentioned. And a phase 3 trial, the goal is really to say, does our treatment really have a therapeutic effect? Because a lot of phase 2 trials can give you a signal, but actually, we know that there's a lot of bias in how physicians select patients to go on these trials. They may select better patients. They may be treated at centers that just have a better overall, standard of care. And so you may be a little bit misled by some of these signals. And so a phase 3 trial is really designed to overcome those bias and say, should this become the new standard of care for these patients? And what we're doing in this trial is randomizing patients. And so some patients go on and they get the standard of care, which in this case for our patients with recurrent glioblastoma would be to go in and get an additional surgery. So they'd get additional tumor removed, and then they would get a chemotherapy drug that's existed for quite a long time called lomustine. And so they can go on and get this treatment, which is the standard of care for these patients. If patients are randomized to the experimental arm, they would get our device implanted, and then they would get the blood-brain barrier disrupted using ultrasound every time they get chemotherapy. And in this case, we're giving a different kind of chemotherapy, also an older drug called carboplatin, but it's a drug that doesn't really cross the blood-brain barrier very well. And so, we think based on our preclinical work and some of these early clinical signs that if we can get the drug across, we can actually improve the efficacy of this drug and see some effects. And so the trial is designed really to randomize patients between these two arms and to look at the end at overall survival. Are patients actually living longer who get our intervention versus patients who get the standard of care? And if we can show that, then the treatment can get approved. It can by the FDA. We're also running the trial in Europe. So in Europe, it will also be available. And then it can, become more widely used, I guess, as hopefully the new standard of care for these patients.
Yeah, that would be something that would be amazing. And I guess, I understand clinical trials to an extent, that going through this and things like that and speaking to other people. And I understand the length of time it takes for things to get done. A lot of clinical trials or even new therapies, things like that, they don't happen in the U.S. They happen in other countries because it's kind of easier to go through that or, whatever the case may be in the factors. But I understand it takes quite a long time because obviously we're 11 years in at that point from, kind of first patient before this. But I hope that something like this or something along this lines can have that effect in positives. And so I would ask on a percentage wise, like what is the percentage of patients that are positively reacting to this versus some that are not, if you have a number like that?
Yeah, that's hard to say at this point. We published our phase 2 results. I guess I'll back it up to give you some perspective at first. I mean, if we take temozolomide I mentioned for glioblastoma, there's a biomarker, which is another thing, but we can kind of predict which patients may respond to that drug. And right now, we know about 40% of patients may have some response to that drug. And despite the fact that may seem kind of low, because it's the only drug out there, doctors are still giving this drug to every patient. So we know, more than half of the patients aren't going to respond. Yet this is an effective therapy and basically the only therapy for these patients. In our phase 2 trial, we published this and we were encouraged because we saw, on the order of half our patients were showing some evidence of response to the therapy, where we actually looked at MRI scans and we tried to look at their tumor growth and, so we saw maybe 50%, maybe a little bit less, I think, were responding. I don't know if that will hold up in the pivotal trial, but we're encouraged, for an oncology therapy in a cancer like this, if you see 20-30% of patients responding well to the therapy, that's already, I think, moving the needle for these patients. Might not sound great as a patient, but I think that, the progress tends to be incremental. And I think that it's a little bit different with our device because once we can show with this drug that we can get an improvement in survival, we can then open it up and use all kinds of other drugs. So there's certain, regulatory aspects we have to get by to first show an efficacy signal with a drug. And after that, I think we can use other drugs and go even further much faster.
Yeah, I think, any positive outcome, whether it's 1% or 100%, is a positive move in a world like cancer where we're trying to figure things out in a better way and give patients a better chance at a better future, not only to beat it, but to not have the long-lasting side effects of everything they have to go through with these types of treatments. You mentioned carboplatin. That's something that our daughter had. She had carboplatin, cisplatin, ifosfamide, etoposide. I mean, all these types of drugs that essentially are in the toolbox of the doctors that they're currently with. And I think most physicians in the pediatric world, I think, are very limited geographically, even because they learn what they learn where they are, and they know what they know based on what they're taught and what they know in their colleagues. But across the country, on other sides, even states away, there's different types of therapies, and there's no real standard of protocol for each of these types of cancers. And to have something like this that could be in a physician's toolbox that would be an addition and maybe give them that leg up to help get these drugs, archaic as they may be, to where they need to be to take care of that tumor and that cancer, I think is only a positive move. So, here's hoping that the trials continue to show positive response and that you can continue to move forward and give our oncologists and our pediatric neurosurgeons and everything, give them that next tool that they need to make a better impact.
Yeah, I mean, I think you're spot on. I think all the drugs you mentioned all have been used in glioblastoma as well, almost because, they've all been explored in brain cancer. So there's a very limited toolbox right now that most of them use. And you talked as well a little bit about the different things that the different clinicians use, and there is some gamut, as you might know, as you've been to different centers and their willingness to test different drugs and things. And I think even in the ability to take risks, some doctors are a little bit more willing to take some risks and to try new things, and some are very conservative, since there isn't always evidence as to whether they'll work. But yeah, hopefully we can change that, and we can bring some new therapies to these patients that haven't been tried before.
That would be the ideal outcome to all of this, right? To be able to give that extra step, that extra push forward, so people can have that option. We as parents, or we as advocates, or we as patients, whatever it is, depending on your situation, we also do plenty of research, and we become Google doctors. We're not supposed to, but we become Google doctors, and we try to figure these things out and look for these new therapies. You will get kind of a 50-50 split with your clinicians on whether they want to listen to what you're saying, as in cast you off because you're not a doctor, or give you an opportunity to bring new things and say, maybe we should try this. And a lot of hospitals or wherever you're being treated are limited in what they can use and what they can do. But hopefully, again, if we continue to build that toolbox up, then we have an option, moving forward. And again, as doctors, don't take it like we're trying to take your job, or we're trying to think that you're not giving us all the right answers, but it's our life, right? Or it's our kid's life, and we're just trying to, give all the options possible. And, sometimes we find out things that, and we research and find things that you didn't know about. And it's okay, just to continue to learn.
Yeah, I mean, I think that's spot on. I think that I hear that a lot from doctors. They get frustrated by people coming in and saying, being Google doctor. But I think that at the same time, I get to chat with a lot of doctors across the world, really, about these different things. And the thing that you find is that not every doctor can stay constantly informed about every trial that's open, every therapy. And so, generally, if you go to a larger academic center, the doctors may be a little bit more informed. They may attend conferences more often. They may be more networked. Whereas if you're at a community center, a smaller hospital, the doctors just might not really be in that research world where they're aware of different therapies. And so, like you said, I mean, I think it's really important to consult different doctors. And I think that some of the big academic medical centers really, I mean, there's just the top doctors, I would say, that are really aware of all the research going on, might have different ideas, different perspectives than you get from other doctors. So.
Yeah, I think it's very easy to get locked in to what you're doing, locked into how you've always done things, and taking that outside information, especially from a patient or anybody that's outside the medical world, can sometimes be difficult to do. And I've dealt with both kinds of physicians in that manner. Some that are very open to listening to what you have to say, some that'll listen, but they're not really taking it in. And no matter what career we have, we are always learning. We're always getting new information, and there's always new things changing. So just being open to that is so important in this specific community in this way it is. So I had some notes written down, and it says here that you were responsible for leading scientific collaborations with academic institutions. So what exactly does that entail?
Yes, I mean, I mentioned, we're testing this. We have a phase 3 trial that's ongoing with a single drug, carboplatin, in recurrent glioblastoma. We know that we can deliver other therapies. And so what we want to do is gather additional evidence that we can deliver these other therapies, that they could potentially be effective. And so we set up collaborations, with academic labs all over to basically investigate new therapies. One big space is immunotherapy that we're looking at, which is how can we harness the immune system to treat this cancer, and maybe combining immunotherapies with our system could be a path to not only extending survival but curing the cancer. And so we're looking at that with several labs. That's super interesting. We're looking at different drugs and working with different startup companies as well through academic collaborations to test their therapies. Also looking at other diseases. So we're just touching on cancer here, but also we have applications in Alzheimer's, Parkinson's, ALS. All of these untreatable brain diseases have this aspect of the blood-brain barrier that really limits drug development. And so we think we can have an impact in some of these other diseases as well. After we get this first approval hurdle over, then we can also look at some of these. And so we're doing early research with different labs to look at these other therapies, other indications as well that we could potentially use our system for.
Yeah, I think, and you're not going to find brighter minds than these labs, or where you're going to have students or teachers or professors, whatever, that's what their goal is, to do this. And I've had the opportunity to tour a lab here and meet some very, very bright students that were studying neuroblastoma, and the way that they can speak to you, and the way that they're not clouded with everything that they're in their 20s. They've got their whole life to kind of learn about what's going on, and it's incredible what they can do and what they're willing to do. And I'm a road less traveled by, so to be able to find something new and different, I think, is huge. And this, to me, is something that in cancer treatments or in therapies and things like that, we don't really hear anybody talk a lot about the blood-brain barrier. We talk about developing new drugs, developing, new immunotherapies, developing or new surgical techniques, or whatever the case may have you, but they don't really talk about getting it to where it needs to go, getting those drugs to where we can develop drugs all day and therapies all day, but if they're not getting to the right place, then we're essentially kind of standing still and spinning our wheels. And so this is, I think, the most positive thing that I've heard in a while, is by being able to get to that point and break that barrier, even temporarily, to allow the therapy to happen properly. I foresee really positive results in that, and I think that's commendable in itself.
Yeah, I mean, I think you touch on some interesting points. You're right. There's a big focus. I mean, especially in neuro applications, there's been a big focus on the therapy itself and new molecules and new drugs, and a lot of people have ignored the blood-brain barrier, as you mentioned. And this has happened across different indications, and it's been a reason potentially why a lot of trials have failed. I was recently I guess it was a few years ago, maybe more than a few years ago, but I was at a conference on childhood brain tumors. There's a lot of work ongoing using convection enhanced delivery in kind of the childhood brain tumor community, which is, you can think of it as just kind of putting a catheter right in the brain and injecting your drug. Mm-hmm. And so they're pretty aware that they do need to overcome the blood-brain barrier, and this is one way that's still being researched and tested in clinical trials. And it's an interesting technology that can be used to get drugs directly to the tumor. The issue with it, one of the big issues with it, is that it's hard to do repeatably. So you can't really leave a catheter in the brain of a patient for an extended period of time and keep giving therapy. And so that's one thing, at least out of many, that we can kind of overcome, is we can, put in our implant and we can do a repeated treatment for these patients to overcome the blood-brain barrier, which is a little bit unique in terms of what's been studied in the past for some of these things, and which is still being studied as, other technologies for overcoming the blood-brain barrier.
Yeah, I think that's something that I've figured out it was after our daughter's stem cell transplant, was that we had noticed that at that point the cancer cells actually were reactivated and kind of flushed through her body through her CNS fluid. And I questioned why we never did that intrathecal, just to put the catheter up here, the reservoir, and go that way. I questioned, why would you not treat the source? Why would you treat it the way we treated it? And I've never really gotten a really solidified answer on that, and why we never treated it that way. I know that it wasn't an option later on, because she had shunts installed, and at that point it would just wash away anyway, so it would be useless. But I always question that. So I'm glad to hear more about this. I'm glad to hear that there's that there's a focus on really getting things through that barrier, because for the longest time, that was always one of the biggest questions to me is why would you not treat the source, for blood cancers, for bone cancer, for anything else, treating it in as a port or a central line, it's getting essentially to where it needs to go. But treating it here to go here didn't really line up to me. And so again, still not, I appreciate, what you guys are doing. I appreciate that explanation too. I just never understood really why kind of a standard of care wasn't to treat the source like that. And, I get it over time, really disrupting the brain is probably the last thing that you want to do and mess around, and surgical procedures or anything in long periods of time. I get that point, but just in general, it's never really been an understanding to me, I guess.
Yeah, interesting. Yeah, I can't speak to the specifics of the cancer that you guys were treating. I know that for intrathecal delivery, it is used. For sure, it's a potential. Again, I think there's very few therapies that we can safely dose and that they use intrathecally for some of these cancers. The other thing is, depending on the spread and the extent of the cancer, we know that intrathecal delivery doesn't necessarily get to the brain and the tumor. So it does treat certain, a cancer that's spread that can be accessible by the CSF, but doesn't always get to, the brain tissue the way that, I think we can get there by disrupting the blood-brain barrier. So it's a little bit different pathway.
Well, I'm positively looking on this at 100%. And again, hearing about new therapies like this is always bittersweet for us as a family, because we didn't have this option and we didn't have the opportunity to really have this chance and try something like this. However, hearing that things are happening in that way, because again, I will say it from pediatric cancer community, we always look on the outside and say nothing's happening. Research isn't happening. Trials aren't happening. Nothing is changing. And again, that's the way we look at it. I've been able to see it from the inside, speak to people, to be realizing that it is happening. Maybe not always specific to pediatrics, but there are advancements happening. So it's bittersweet for us, but positive for the community and for the cancer community as a whole.
Yeah, I think I remain optimistic. I think there's so much research, so much amazing research going on. From better understanding the cancer biology, which you have a lot of labs just working on that, identifying new targets that we can use to treat cancer, working on the delivery that we talked about today, working on personalized medicine aspects, which is, how do we overcome and not just treat, know that we're going to be effective in 50% of patients, but 100% of patients by identifying patients in advance that might respond. There's just this huge spectrum of things ongoing in the research world that I get to see, at conferences on a regular basis. So I guess I remain optimistic that we're going to get there. And as you mentioned, I think even if they aren't being studied directly in pediatrics, they're all going to come to pediatrics as well once we can establish that they're safe and really work in patients. I'm optimistic that we're going to move the needle quite a bit on these cancers in the near future.
Excellent. That's exactly what I want to hear, and I know so many people want to hear as well. When, obviously we want everybody to understand that pediatric and adult cancers, although might have the same name, they are completely different within these communities. Their bodies handle it differently. Therapies are different. Options are not always the same for each group. And so having options that could potentially be the next step, the next level, the next tool in that toolbox that I keep mentioning, that could give our kids a better chance at a better recovery and even a better life moving forward is all that we're trying to do here. So I appreciate what you guys are doing. I appreciate, the years that have been put into this and the years that will continue to be put into this. It doesn't sound like you or Carthera, it doesn't sound like you guys are slowing down at all. So
not at all. No, we're running our clinical trial right now at over 40 clinical sites, trying to make this available to as many patients as possible right now in our clinical trial. And hopefully, if we can show that it's effective in the next several years, then we can make it available to many more patients.
And just on a quick, are the clinical trials all being run outside of the U.S.?
No. So we have 40 clinical sites. Roughly half of them are in the U.S., scattered all over the country. Some of the big sites, you're in Wisconsin, I think?
Yes.
I'm from Wisconsin, so
okay.
We're working closely with Northwestern, which is an amazing academic center. We're doing a lot of research with them and their trial site, working with the Mayo sites, UCSF, Columbia University, kind of a bunch of sites in Florida. So we have sites kind of scattered all over the U.S. and then all over Europe as well, with sites participating in this trial.
Okay. Well, that's excellent. I mean, I'm glad to know that it's kind of right there, right in our backyard, essentially. So that's good. And I know there's no definitive number, and there's no way that anybody can put a number on this. You think that we're still years and years or multiple years away from having complete FDA approval for something like this?
Yeah, so I mean, these trials take time. So you need to enroll enough patients and then wait and see if whether you're actually having a treatment effect. So in our trial, we're trying to finish enrollment next year into the trial, and then we need to see if there's actually treatment effect. If there's a big signal, and we can come to the FDA earlier and say, hey, we have a big signal, we're really seeing a positive effect in patients. Sometimes the FDA does approve these therapies much sooner before you actually wait for the trial to finish, to completely finish. And so that's our hope. I think in the best case scenario is that we can come to the FDA with data that leads to an approval sooner rather than later.
Okay. Well, it's hopeful, and I know that the FDA, again, and much like the government, things move at a snail's pace with that kind of stuff, but it's the effort is there, the work is there. I think that the positive results, again, like I said before, whether it's 1% or 99%, it is a positive result if you see any, and it's just a chance for you to tweak it just enough to make it work and make it positive in so many more patients. So definite positive move forward here. Is there anything else that you would like to add that maybe I didn't ask or didn't cover about this, or anything else you guys have got going on right now?
I don't think so. Yeah, I mean, like I mentioned, we're running a phase 3 trial. We also have some phase earlier stage trials running with other therapies as well, particularly at Northwestern. We have a trial in newly diagnosed GBM patients that we're looking at immunotherapies with, and so we are kind of looking at a bigger spectrum of therapies as well, even in clinical trials, as well as, like I mentioned, preclinical work and collaborations that we have. For our phase 3 trial, there's more information. We have a website, sonobird.eu, that has the list of clinical sites in case anyone is interested. You can find the sites that are closest to you and reach out if you are interested or know someone who may be interested in this trial.
And just for kind of clarification, because I kind of have a general understanding of clinical trials and how you get into clinical trials, what are the requirements for a patient to be enrolled in one of these clinical trials?
Yeah, I mean, so it's a long list, and so we typically have inclusion criteria into a trial. In this case, our phase 3 trial is for patients who have had an upfront treatment using the standard of care, and so they've had surgery, they've had radiation, they've had temozolomide, this kind of standard of care that a patient would get. And then, they've had an MRI that says, hey, your tumor has come back and it's growing again. And at that point, these are the first recurrent glioblastoma patients that we're enrolling on our trial. They have to be eligible for surgery. They have to have a certain tumor size. And then, there's some other eligibility things as well. We try to keep it as open as possible to allow as many patients to come on trial as possible, but then there's also some things that we just can't avoid to kind of limit the types of patients that can come on the trial.
Sure. And I know that you had mentioned earlier, or we were speaking earlier about it now, are the clinical trials open to just adults right now, or are there kids enrolled in them at all?
Yeah, so this trial is for adult GBM, so it's patients, adults only. Like I mentioned, we do have a pediatric trial that is open in Paris for high-grade gliomas that's enrolling as well. But that's our only pediatric trial at the moment.
Okay. All right. Well, that's, again, if I will put all the links in the description so everybody can look that up if you're interested in learning more about this, or where the sites are, or even if it's something that you want to look into the trials, I will put the information in there so everybody will have that. And so I'll just ask again, is there anything else that I missed, or anything else you'd like to add to kind of let people know anything like that?
No, I think we covered most of the points today. Yeah, I really appreciate the discussion, and happy to, people can reach out if they want to learn anything more about our technology or our trials that are ongoing.
Excellent. Well, I appreciate it so much. Again, like I said, it's eye-opening, and it's definitely something that doesn't get talked about enough. So I'm glad that there is a solid focus on this potential game changer within the community for both adults and for children, because anything that happens on one can happen on the other, and I'm so excited to hear the future. So thank you again for being with me today and explaining all of this to me and everybody so we can better understand it.
Awesome. Thanks so much, Curtis.
Yep.